sir. May I introduce you? Bismillah ar-Rahman ar-Rahim. It's a great honor and a great pleasure for us to be with us tonight, one of the eminent guest stars and guest speakers in England and all over the world, our dear Professor Alistair Phillips from Southampton will speak about the Walant technique, which he is the innovator of this technique. Thank you so much, sir, for being with us tonight. And with us will be moderator, my dear friend, Mr. Rami Sharif from UK. Thanks. I would like to thank him for his effort in arranging all the sessions of our dear English guest speakers. Thank you so much, Dr. Rami. Now we will start with the first talk of Dr. Phillips. Thank you so much, sir.
Thank you very much. Right, without further ado, let's do some sharing. I hope you can all see that. Are we on, Rami?
Yes, sir. Yes, sir.
Excellent. So some of you may have heard of Walant. Some of you may have watched Don Lalonde or myself or one of the other eminent Walant volunteers, as we're called, talking about this over the summer. And I've been asked to talk about the very, very basic. So it's not a regional anesthesia. When people talk about wide awake hand surgery, they talk about the patient being awake. But the patients are awake, but their whole arm is not anesthetized. They do not, on the whole, have a tourniquet. But as I said, never say never. Sometimes tourniquets can be useful. If you're going into a revision situation, local anesthetic works very well, but because the scar tissue doesn't have nerve endings in it, but the scar tissue does have blood vessels in it. So if you've got the adrenaline in with the local anesthetic, the adrenaline doesn't close off the blood vessels in the scar tissue, and therefore it can be quite difficult to see what you're doing in the revision situation. Under the vast majority of the rest of the time, the adrenaline gets into around the blood vessels and stops what you need to stop to see a perfect field. Now, this is the magic ingredient. This is adrenaline. Okay, and it is a magic ingredient because it is the addition of adrenaline that allows us to do everything else and all of the other things that come from it. I know in Egypt there's a lot of enthusiasm for Walant, but there's a lot of fear as well. And that is exactly the same the entire world over. So in France, it's actually illegal to use adrenaline in local anesthetic in the hand. People use it and it's accepted, but it is still technically a criminal offense. There's lots of places in the world that don't read the literature and will never use it. And again, what we're trying to do is calmly use the evidence to state that how safe it is. So up until 2012, there was no single case report of lignocaine with adrenaline causing finger necrosis. There have been 4 case reports, and we'll go through these in a little bit more detail later. But essentially, Raynaud's phenomenon, if the finger's got problems with its vessels at the beginning of the case, you are more likely to have a problem, and therefore, personally, I stay away from Raynaud's. I stay away from atherosclerosis in digital vessels, and I certainly don't inject into the tendon sheath, because what happens if you do a digital block into the tendon sheath is the local anesthetic and adrenaline flows up the sheath all the way to the fingertip and comes out at the fingertip. So you're missing most of it. You get a block because on the way in, you're injecting into the subcutaneous fat. But what you're doing is forcing all that adrenaline to the fingertip, and it doesn't like it there. So if you're going to put adrenaline with local anesthetic into the skin, don't put it into a compartment, just put it into the area around where you're trying to go, and then you put lots of volume, and then it will flow to where it wants to in a safe manner. Don't force the local anesthetic where you think you want it to go. It will do its thing. Okay, just come back slightly. The other thing to say is, medico-legally, if you're going to use Walant, you really should have phentolamine available in your hospital. There's no rush. You don't have to have it like an EpiPen sitting on a cart next to your operating theatre. You need to have it stored in pharmacy and just have one vial, and you use 1 cc or 1 milligram of phentolamine in 1 milliliter of saline, and you put it into everywhere where you've just injected. So if you injected 3 places, you put 3 injections of 1 milligram with 1 milliliter of saline into each of those injection sites, and that will reliably reverse the adrenaline. And then you've got a pink finger again. Okay, the local anesthetic won't work as long, but if you're worried about it, try it. I must say I've done thousands of Walant operations, as has Don Alond and all the other volunteers, and I've never used phentolamine. I know my pharmacy have it, but I've certainly never used it. But it is very, very safe, and I would challenge anybody in this day and age, with the amount of evidence there is out there about using adrenaline, I would challenge anybody to go to the literature and not be able to find enough evidence to be able to use it in their hospital. So this is what we use in the UK, xylocaine with adrenaline. Our formulation comes as 1 in 200,000, but you can use 1 in 100,000 if you want to. In Canada, for example, Dom's got 1 in 100,000, and we use 1 in 200. You can buffer it with 8.4% bicarb, 1 to 10. Personally, I haven't found the need to at the moment. I don't bother. And I know a lot of people who don't bother, and a lot of people who do prefer to. It does, the buffering does theoretically increase the bioavailability of the local anesthetic and makes it work faster. But I haven't found that to be a problem. It is, however, important to be nice to your patients. And this is something I'll go through in a little bit more detail later, because when you've got an awake patient, you need to look after them. You need to have gain their trust and gain their engagement in you and the surgery. So if you start putting big orange or blue needles out and you hurt your patient right at the beginning of the case, they're not going to, that doesn't really inspire faith and trust in you as a surgeon, because it doesn't really tell the patient that you're empathetic, emotionally intelligent, for want of a better phrase. It doesn't tell them that you're involved and engaged as a surgeon, so why should they be involved and engaged as a patient? If you use little needles with very slow injections, and you always pushing local anesthetic ahead of your needle tip. Honestly, when I had my surgery, I felt the first needle go in, obviously through the skin, and after that, I didn't feel a single thing, and I had 20 mils put into my hand. So as I said, it is the adrenaline that if you start with that and you add it to your local, you don't need a tourniquet, because the adrenaline closes the blood vessels down. If you don't need a tourniquet, you don't need a block, because the block is there to cover the pain from the tourniquet when you're doing anything more than 15 minutes. If you don't need a block, then you certainly don't need an anaesthetist. If you don't need an anaesthetist, then everything is just a lot easier, quicker, safer, and cheaper, of course. So if you take it back to its origins, it's the adrenaline that makes the big difference. And we now know that it's safe. So why should you take up Walant? Well, it is simply a local anesthetic technique. I totally appreciate that. And there's a lot of people around the world who just say, yeah, but I use local all the time. Okay, I get that. And you know, carry on. Absolutely fantastic. What's different about Walant is that what we're trying to achieve, and you can do this without adrenaline as well, but if you've got a tourniquet on, that patient's going to start getting very, very tetchy and painful at about 15 minutes. And I can testify to that. I had mine on for 22 minutes, and really it was extremely uncomfortable. And it stopped me moving during the case. So if you want a compliant patient who's going to help you and you do surgeries that last longer than 15 or 18 minutes, you're going to need to take that tourniquet off. And if you take the tourniquet off and you get reactive hyperemia, you can't see what you're doing. Whereas if you use adrenaline right from the start, 18 to 20 minutes into your operation, you've got a pretty dry and share the really blown up like you wouldn't believe on LinkedIn. And this chap, Amir Adham, Malaysian guy, absolutely fantastic surgeon, and he's done tibial. He's got a series of clavicle fractures. That makes me too nervous to do a Walant clavicle. I don't need a pneumothorax, thank you very much, with an awake patient. Although I guess they'd tell you if they were not breathing very well before they tensioned. Anyway, and again, the hashtag Walant, of course. Do follow me. I'm not massively active on Twitter, but LinkedIn and the website are very, very good sites. So thanks very much for listening.
Thank you so much, Professor Phillips, for explaining to every one of us.
Thank you. Thank you, Mr. Phillips, for your smash one, and was asked about dose of adrenaline would endanger.
That it works. And then it's the same principles, and the vessels. You're never going to close down an artery with Walant with the amount of adrenaline that we're using. Stops is the ooze, the bloody ooze. Next question.
Yeah, perfect. Thank you very much. There's a question. Yeah, there's a question about the efficacy of local anesthesia and the use of tourniquet. Is there any correlation between both of them?
The efficacy of local when you're using a tourniquet. No, not as far as I'm aware. I mean, local works. That's why it's called local, I guess. It works locally. If you don't have blood flow through the arm, that local will stay around. That's the principle of a Beers block. But the local anesthetic will stay for 4 to 5 hours with adrenaline. I've never quite understood that, how it lasts for 4 to 5 hours when 1% lignocaine lasts for 20 minutes. I know the adrenaline obviously does the effect, but adrenaline gets metabolized very quickly and as well. So I still can't answer that.
Dr. Rami, are with us?
For the uses of Walant technique in nerve repair.
Yeah, I do.
Please.
I guess you have to. I mean, yes, you can.
Walant technique.
You can use it in nerve repairs. The thing is, you have to ask why you're doing it. If you want a dry field and you're doing a 1 millimeter nerve, you don't need Walant. You need a really good repair. So you want a dry field. There doesn't seem to be any benefit to using Walant other than it's cheap and easy. Whereas if you've got an aesthetic service and you can do good blocks or a quick general anesthetic, actually sometimes if you're not going to do intraoperative movements, if you're not going to test your repairs, which you're not going to test your repair with a nerve repair, I hope. I can't quite see the point. Yes, you can because it's easy, and yes, I have done it. But sometimes you just have to be a bit more pragmatic and say, how is Walant going to help me? And sometimes it really isn't going to make any difference. So then you can just pick and choose whatever you want to do.
Perfect. Thank you very much. Your paper, Mr. Phillips, 2019, practice in wide awake, and it was a difference between United Kingdom and Cyprus. So what is your message for these different services?
So in Malaysia, can't get into theatre. So he wants, because then he can do it, and that's why he's done tibial fractures, etc. I have an amazing anaesthetic service, and therefore I don't need to do tibial fractures under wide awake. I don't need to do distal radiuses under wide awake because I can do a block on them. I don't need to check my distal radius fracture fixation with active movements. Whereas in Cyprus, it's mostly private, and Costas needed a way of reducing the cost so that patients could get their things. So if you look at all the different reasons for doing Walant, and if it works for you, then great. If it doesn't work for you and you don't like your patients being awake, then absolutely stick to what you're good at. Because what we don't want is for patients to have surgery under Walant, and then the surgeon just freaks out. Far more likely than the patient. The patient doesn't freak out at all. They love it, honestly. And it's the young men. The young men absolutely love it. They get their phones out and they start doing selfies during the case and leaning over. And I'm like, get off, get off. You can't be that close. Stay away from me. So yeah, it's personal choice, but there are lots of reasons to do Walant. So you pick your choice and run with it, I think.
Perfect. Thank you very much. It is a brilliant technique, and we need to raise the awareness of the surgeon about it. And that is the whole idea from your website, to increase the awareness about these techniques. And your website is amazing. A lot of videos and explanation and education and papers about it. So what is your message for young surgeons to adopt this technique and be safe during doing these techniques?
So what's really important is that you have an evidence-based practice. All the evidence has been accumulated over years and years and years to say that it is safe, it is effective, and for certain things, it really should be the go-to anaesthetic. Flexor tendons, extensor tendons, phalangeal and metacarpal fractures, I would say I would never do not under Walant again. In fact, the only GA extensor tendon repair I've done in 5 years failed. Every single Walant one has not failed. So there's a salutary lesson there. The key is, I think, to have a good mentor. So find somebody who's comfortable doing it, stick with them, get your evidence together, read it, learn it, and then try it. If you try it, it's so safe. Put a tourniquet on if you want to. Have an anaesthetist on standby if you want to. You know, I did a scapholunate ligament reconstruction under Walant. It was terrifying. Absolutely terrifying, actually, because I didn't know whether it was going to help me or not. And actually, it was massively helpful. It was really, really helpful. But I got my anaesthetist to do a forearm block, and I put local in locally, and we shared out very dilute local anaesthetic. So, you know, there's a place for an anaesthetist if you're worried. If you think the patient might need some sedation, have them hanging around. But really, if you can get away with it, the vast majority of the patients, if you talk to them nicely, they don't need it. They actually really quite like chatting to you. I had a professor of oceanography in my theatre today, and then the next guy was a professor. He did particle physics and absolutely blew me away. And I was just busily getting on with the carpal tunnel, and I didn't have much time to chat to him. But you know, so get to know your patients, get to know the techniques and the evidence, and then just do it, and then just get on and do it. Stop reading and start doing.
Brilliant. Thank you very much. My personal feeling about Walant, it is like Aladdin lamp, and I just rub it and the genie will come to me. There is no, I don't need anesthetist, I don't need main theater, I will do it in minor surgeries. I don't need any preoperative assessment, headaches, and the patient will go home right away. So what is the plan B? What is your plan B in case of something went wrong? So
sure.
Do you set usually plan B for in case of problems?
I don't like putting in metalwork in minor ops. I know it's done. I know in Canada they do. We have a system in the UK which doesn't really favour that. My nurses aren't very used to doing it, so until I've trained them up a bit more, I'm not going to do that. I'll put metalwork in theatre, main theatre, because the reason to get them in the minor ops room is using field sterility, which is a separate technique, which lends itself to Walant, but it's not actually the Walant that allows you to do it in the minor ops. So plan B is, well, I've never had to give a patient sedation. It's usually blindingly obvious before you put them on the waiting list if they're not going to accommodate local anaesthetic. But equally, it's how you say it, isn't it? You know, if you went up to a patient and said, right, you're going to have an EIP to EPL transfer, as we've discussed and as you've wanted, I do these under local anaesthetic. They go, okay. You know, and you just get on with it. And if you are comfortable, I think there is a certain amount of, if the surgeon is comfortable, the patient will be comfortable. And certainly the first few, when I was doing that scapholunate, I did go quite quiet at one point when things weren't going very well. And I'm brutally honest with them. I said to him, right, can we all just concentrate a little bit, because this is a tricky bit. I really want to get this right. I'm struggling a little bit, but I'm sure we'll pull through. And he was fine. He got a bit nervous. And I went, right, I've done it. Everything's fine. And he went, okay, great. So you do have to be honest. If things go wrong, I did a Dupotrons the other day under Walant, and it was a revision of a revision, and I cut the neurovascular bundle. You know, it happens. And I said to the guy, I'm really sorry. You know that thing that we talked about beforehand that might happen? It's happened. And he goes, oh, you know, you talked to me about it. That's not a problem. Don't worry. We discussed it. It's going to give me a little bit of numbness, but that's okay. And he was fine. But you have to do it. You have to talk to your patients and tell them the truth. That's plan B, is tell them the truth.
In your presentation, you have described very well how to pick up a case for Walant technique, but this question is about how to pick up the right patient for Walant technique. Do you have a selection criteria for your patients? Like, I don't want to hear Vesics, professor of Vesics will not be in Walant technique.
Sure. No, I offer it to all of them. And I just find, maybe it's our patient population. It might be different in Egypt, France, everywhere. In Canada, if you injure your hand, you know that you're going to be awake. You know, if you're a lone soldier and you're the only one doing Walant, that's more difficult, because they might have been put onto or somebody might have discussed the case with the patient before you get to see them, particularly with hand trauma. You know, they might be seen by a junior doctor in the emergency department who says, oh, yes, you'll be put out and you'll have 6 weeks in a plaster and all this stuff. And then you're just backpedaling, trying to undo the misinformation that they've been given. Obviously, everybody knows that I'm going to do Walant, but I'm the only one that does Walant a lot at Southampton. Professor Warwick, who was on last week, he does some, absolutely. When he finds an indication, he'll use it. But it's difficult. You do have to set the patient up. And for elective practice, it's much easier. So you just say, right, I'm going to do this EIP to EPL transfer under local. That's how I do them. Is that all right? And they go, yes.
Perfect. I have received a few questions about your technique, your preferred technique of Walant. Do you inject the periosteum of the bone? Is it slow injection? How much lidocaine?
So,
about
yeah, I'll do a little bit on that if you like. So,
in what?
Sure. So small needles, I use a 27 gauge, which is small, the one down from an orange needle. And I use a 40 mil needle, which is like the dental needle, so very long but very thin. So you go in once, you inject, and then once that initial injection has worked, then you can start blowing up the local anesthetic under the skin. And really, you only need to put the local anesthetic under the skin, not in the skin, because that hurts like hell, but you put it under the skin and you almost hydrodissect a big lump of local anesthetic under the skin. And what that does is you get what's called a tumescent technique, where the pressure of fluid in that bulb of a mound of fluid pushes the local anesthetic around. And then I get the patient to give it a bit of a massage as well. So trapeziectomy, sometimes you need to, if you're going into the joint, you want to push some local into the joint as well. But again, if you do it in the surgery, once you get to the joint, you just put a bit more local in. So it doesn't go into joints very well. So if you're doing base of 4th and 5th CMC joint, fracture dislocation, you can put 20 mils across the back. Yeah, and then you go down between the metacarpals and you put a little bit more, maybe 5 either side, and then you just go into the fracture or into the dislocation and you just put a few more in there. And you can do a median nerve block at the front, but it's a field block. That's the other thing that's really important to say, is you're putting local anesthetic in as a field block. You're not targeting nerves or anything like that. You're just flooding the whole area with local anesthetic so they don't feel it. Does that make sense?
May I have a question, please, sir? Have you seen any reactions or anaphylactic problems with this technique?
No. Young men tend to faint. They're certainly the more common fainters. And if you have that, you just put their head down, lift their feet up, and they're usually fine, and then you carry on. No anaphylaxis at all. If you want to be really, really safe, you can get ampules of adrenaline, you can get ampules of local anesthetic, and if you mix them up to 1 in 100,000, then you don't have any preservatives in. It's the parabens that people are most often allergic to in the xylocaine with adrenaline, methyl parabens, so, which are the preservatives. So if you get rid of those, then but no, I've never seen it. Never seen it.
Any
Or
questions?
compartment syndrome. There was a question about compartment syndrome, and I've never seen that either. No, I've injected 150 mils into a forearm, and it didn't work. You've got a big open wound there. It's going to come out.
May we proceed with the next presentation, sir?
Absolutely.
Thank you.
Are we good?
Yeah.
Great. So you've learnt the basics. You've gone away. You've done carpal tunnel. Maybe you've done EIP to EPL transfer, which is definitely the next one to do. You may have even done a tendon or two, and then you want to do a bit more. So this is everything that has been written up in the literature. I've done most of these. And the reason I put tibial shaft and clavicle in brackets is because I struggle with them because I have such a good block service. Now, Amir doesn't have a good block service and an anesthetic cover, so he has done a large cohort of clavicle orifs. And I can't, for me, it's not necessary in my hands. Tennis elbow release. Mike Hayton has a fantastic video on ViewMedi, which I thoroughly recommend to everybody. ViewMedi.com, ViewMedi. And Mike Hayton from Wrightington has a fantastic tennis elbow release video. which I just do as my standard now. Mid-shaft forearm fractures, again, if you've got a block service, I just do these under regional or general. Same with distal radius. If you need to do it in your hospital, then you certainly can, and there's techniques written about that. Mike Hayton has also done wrist arthroscopy, so he calls it dynamic wide awake wrist arthroscopy, DWAWA, which I think is a great name. And he's certainly seen some very interesting things under active movement rather than passive movement. Radial head, yeah, actually that was quite useful to get the patient to rotate rather than me to rotate. Olecranon definitely was useful because I did a tension band and got the patient to extend, and there was no gapping, so I got the patient going straight away. Whereas sometimes I'm a bit more cautious. Ulnar shortening, I won't do another ulnar shortening under a GA or regional ever again. It's a subcutaneous bone, it's easy. And the scapholunate ligament reconstruction, actually that was quite helpful. What I noticed was that when he gripped, the bones came together, which is what Mike also saw when he did wrist arthroscopy. And he got the patient to grip, and the bones came, the scaphoid and the lunate came together, not drifted apart. So when I did the scapholunate ligament reconstruction, any radial ulnar deviation after I'd fixed it really put a huge amount of torque on the scapholunate ligament reconstruction. But the flexion extension didn't. So I then didn't put any wires in, didn't immobilize the wrist, and I did flexion extension for the first 4 weeks, and I didn't let him radial ulnar deviate for 8 weeks. But I allowed him flexion extension. So he had a near normal range of flexion extension by 8 weeks post-op, which is when you're normally just trying to take the wires out. Patella orif, yeah, if you've got a patella fracture, nice transverse patella fracture, and you want to check that you can get them moving quickly, get them to do the active quads flexion and full knee flexion, active quads tension and active knee flexion, and then you can test your fracture repair, and then you know how quickly you can rehabilitate them. So when I do this, I tend to get them to flex the knee to 90, 100, 120 degrees. And if there's any gapping, take them a bit more slowly, but if there's no gapping, then off they go, and they're basically free range of motion from day one. Ankle, forefoot, there's a lot more forefoot and foot and ankle Walant coming through, but again, it's more difficult for sure. So these are some of Amir's cases. The lunatic that he is, love him to pieces, but my God, that is, you just don't want to see your arm flailing around like that after a clavicle, do you really? But this is all fun. And again, the ulnar at the top there, the ulnar is a subcutaneous bone. It's very easy to anesthetize. And you see how much blood there is pouring out of all of these wounds. They're pretty dry, You're probably an hour and 45 minutes into each of these operations. They're not bleeding, honestly. So this was one of my cases. Sorry, I'll just go back. So this was a climber, bodybuilder, and he had an A2 pulley rupture. So we used a dorsal extensor retinaculum graft, plumbed that into the A2 pulley site. And then you get them to actively flex, and you can see that there isn't a gap between the flexor tendon and the pulley. So I let him go, and he could do, so like with the flexor tendons, you get them to do a full fist in theatre, you check that their flexor tendons not gapping, and then you let them do half as much out of theatre. So I let him do 50% fist for the first 4 weeks, and then full fist from 4 weeks. And this is him at 5 months, admittedly at 5 months. So he's got nearly full range of motion. You can see he's in a gym. So that's 15 kilo weight, and his weight's back to normal, and he's doing all of the weights that he normally does. That's a 20 kilo on the left there. And he said that was as strong as he's ever been using that finger. And he loved it. He absolutely loved having the video, and he showed all his mates, and he just thought it was the best thing ever. So 20 mils of local in the UK costs a couple of quid, £2, which is about 40 Egyptian pounds. So it's very cheap. In hand fractures, which is what I've been asked to talk about, you can still get 20 mils of local across the back of a metacarpal, and then do your metacarpals come quite proximally to just underneath the transverse carpal ligament. So you do need to block the median nerve proximal to the transverse carpal ligament. If you're doing metacarpals, I would suggest. Or you can come in from the back and just infiltrate either side, a bit like a ring block, without having to go through the front. But you've got 50 mils of local to play with, so use it, absolutely. Stick to the guidance. Use peripheral ultrasound guided blocks if you want to, if you're worried. But again, I've only used that once. As I said earlier, you can just get on with it, have a tourniquet on but not up, as all my fellows do when they first start. They put a tourniquet on, even for carpal tunnels, and then after a couple of cases, they just don't even bother. And I would suggest, if you reckon you can get 60 or 70 mils of local anaesthetic into a patient, make it up to 80 or 90, just in case. Give yourself a little bit of leeway, 10 or 20 mils, so that you can have that on the side, just in case. I'm a massive fan of putting in more than I need rather than less, but sometimes you don't want to get to having used your whole 50 mils, and then patient's sore and you're like, oh damn, I've used my aliquot, I can't put any more in, sorry patient, you can't have any more. Just have a little bit in reserve. And my biggest suggestion is take your local, add enough saline so take your 50 mils, and then just put saline with that. It doesn't matter what the percentage is. You get some weird percentage like 0.163 or whatever it is. That doesn't matter at all. What matters is the volume and the fact that it has local anaesthetic in it. And again, there's papers on 1 in a million adrenaline usage. So you can do most of this stuff 10 times as weak adrenaline as what you've got in that vial. So one in a million. These are just some examples of what I would use for flexor tendons, etc. So if you're doing 20 mils for a flexor tendon, you put 10 mils in the palm, 2 mils over each phalanx on the front, and about 10 mils on the back, just to give you your circumferential block. It all adds up to about 20 mils. If you're doing any more than that, usually more than 3 flexors, you're either in zone 5 or higher, so you can put as much as you like in, really. The Scapholunate one, I used 100 mils, and the anaesthetist used some for his, I think 5 mils for his ultrasound guided blocks. They're very stingy, aren't they? But patella, again, you need quite a big volume because you're pulling on tissues. So the retinaculum soaks up quite a lot. On the shortening, 40 usually, 20 on the front, 20 on the back, or 10 on the front, 10 on the back, and 20 over the bone. Just a radius is written up, so there are papers on that, and most of these, if you want to find out how to do it, there's a paper out there somewhere looking at the technique, and again, forefoot and olecranon. The general principle is you put local where the patient might feel it and where you're going to be operating, and it's as simple as that. So this is one of Don's cases. So with hand fractures, do as little disturbance to the soft tissues as possible, because you're expecting those soft tissues to do a lot. They've already had a massive insult with an injury, and then if you go opening them up and putting a plate under the extensor tendon, they're never going to move, especially if you don't let them move early. So check it. So get the wires in. Get the wires in, and then do intraoperative testing. So this is Don doing his proximal block, putting the 0.9 mil K wires in, and then you just get your fluoroscopy out and you test it. Yeah? And you check that your rotation's right, you check that the fractures are stable, and then you know, and the patient knows, that you can move them after a few days. So let the surgical pain settle down and then get them moving with the hand therapist. And it's not aggressive. It's not really super aggressive. Get moving now, get going. You, as I said there, move it within what's comfortable. And then as the pain improves, then do more. Let the body recover and work with it rather than trying to work against the body the whole time. And you need to get them moving for this reason. The adhesions and swelling in the foot and ankle, it's fine. You've got massive muscles to overcome all that swelling and scar tissue. In the hand, we don't. We've got these puny little forearm muscles. Well, me anyway. You've got these puny little forearm muscles that are not gonna overcome all of that swelling and scar tissue. And as I tell my patients, you know, that swelling is fluid that has leached out of the vessels, and with that fluid comes all the good things, which is why it's there, like macrophages, neutrophils, etc., and fibroblasts. But with all of those cells comes fibrin and all the stuff that's necessary to make a clot, but also scar. So if you get swelling in the first place, you've got scar in your hand waiting to happen. So don't let it get stiff in the first place. Get moving early and do as little as you have to make it stable. So here's an absolute classic from my registrars. Base of fifth metacarpal, dislocation, unstable in theatre, and you can pop it in and out of the joint. So you put 3 wires in. That's classic, isn't it? Well, how about doing it under local, putting 1 wire across into the hamate, and then checking again. If it's still unstable, put a second one in. But if it's not unstable, why put a second one in? You don't need to, because the patient's telling you that it's not unstable. So most of my base of fifth metacarpals only get 1 wire, and sometimes it's a 1.25 wire. So, you know, the small wires that aren't going to destroy the joints. Yeah. As a general principle, wires in fingers and screws in metacarpals, plates, okay. I'm quite a big fan of this intramedullary screw technique. I'm really enjoying that at the moment. So for metacarpals, putting Accutrack screws or headless compression screws inside the metacarpal shaft. It's written up, it's all over the place, and I'm really enjoying that. You can get them moving straight away. And non-operative. So I would, if this patient didn't have rotational problem, I would never treat that with an operation. So do we need to do an operation? That's where the other thing about Walant comes in, is it's still got local in it. I haven't used plain local anaesthetic for 4 years. So even in the clinic, I quite often, if they're too sore to move, I'll numb them up in the clinic, send them away for a cup of coffee, bring them back into the clinic, and then test them. If they have a full range of motion and they haven't under local anaesthetic, they can see it, I can see it, I document it, they go away. Phentolamine rescue we talked about, so 1 milligram in 1 mil of phentolamine. We talked about people fainting. And as a general rule, if the finger's white before you inject adrenaline, it'll be white afterwards. And those are the problem children. So just if the finger's normal beforehand, it'll be normal afterwards. I do tend to step down to 0.5% and 1 in 400,000 for people with cardiac problems. You don't have to. Just makes me a little. I don't want to have a problem on the table. I don't want somebody to criticize me and say, well, you know, your Walant technique nearly killed me. And I'm like, no, it's not my Walant technique. And actually, it's perfectly safe. It's just you've got a dicky ticker. So I do. I'm a little bit more cautious with them. I hope I've been through. I know it's a bit of a whistle-stop tour, but I do hope that that has piqued your interest at the very least, and happy for some questions, I guess.
Thank you so much, sir. Any questions, Dr. Rami? I didn't receive questions.
And now we are. Now we are in COVID area, and there are many challenges we face every day in our hospitals. And Royal London Hospital published a protocol just a few months ago about the Walant technique. And should we adopt similar protocols for Walant technique in this situation?
Yeah, it's absolutely gone crazy, the Walant, over the COVID time, and I think it's very, very, very good. There's a published paper looking at the safety of Walant with COVID, and it's perfectly safe and valid. Yes, so the BSSH, I helped write the BSSH guidelines, which are on the Walant website and the BSSH website. And there's lots of management stuff on the website as well. So yes, the Royal London ones are very good. I would encourage you to do cultural specific information leaflets though, because what I tell my patients might be different from what I tell or what you tell your patients. And that's really important because you need to manage your patients in the way that you know how, and you're fantastic at it. I've seen you in action. But you do need to have, you know, some emotional intelligence about how you talk to your patients. And that varies between cultures and languages and all sorts of ways of doing things that you might do that we don't, or we do that you don't.
Brilliant, brilliant. Thank you, Mr. Phillips. Thank you very much. I don't have any more questions.
Fantastic. So the other thing to say is I'm totally happy for people to email through the website. So if you've got questions, or if you've got cases that you want my opinion on, one of us will get back to you. There's a few of us answering these. So you know, please just email through the website. And if you've got, well, what would you do for this? What would you do for that? Always absolutely delighted to receive emails and help out. Don't ever think you're worried. Don't worry about being inconvenienced or anything like that. It's never a problem.
Finally, at the end, I would like to thank very much our dear Professor Alistair Phillips from Southampton. Thank you so much, sir, for joining us tonight. Thank you for this very fruitful scientific session. It was a great pleasure and great honor to be with us tonight, sir.
Well, thank you very, very much, everybody, and good luck in the future.
Thank you so much. Also, I would like to thank my dear friend, Dr. Rami Sharif from UK, for arranging all these very nice lectures and very nice presentations. Thank you, Dr. Rami. Hoping to see you again. Thank you so much, sir. Now we come to the end of the upper limb trauma course, and we will start on next Wednesday, inshallah, at 10 p.m. with the lower limb trauma course with two very important lectures. It's a great honor for me to be the presenter of the first lecture about the fracture acetabulum, and then followed by another lecture of one of my dear colleagues, Dr. Saad, will speak about the approaches of the acetabulum and the pelvis. Thank you so much, and see you, inshallah, on next Wednesday. Thank you, Professor Phillips. Hoping to see you again, sir. Thank you. Thank you, Dr. Rami. Thank you so much, sir. Goodbye.